morning, everyone, or good afternoon, rather. Welcome to our Perform Colloquium with Dr. Elizabeth Teel. Before we begin, I just want to ask everyone to use the Q&A feature at the bottom of your screen to enter any questions that you might have for Dr. Teel, and we'll do our best to answer them at the end of the talk. So thank you for joining, and over to you, Elizabeth.
Thank you very much for having me today. As Wendy said, my name is Liz. I'm an assistant professor in the Department of Health Kinesiology and Applied Physiology. I just started at Concordia in August, so I'm very new, and I'm going to talk to you about some of my previous and ongoing work, as well as some of the future work that I hope to do now that I'm here at Concordia. So my talk is entitled Integrating Physiological and Functional Outcomes, Opportunities to Improve Clinical Care for Individuals with Concussion. So, a concussion is a traumatic brain injury induced by biomechanical forces to the head or the body, which results in pathophysiological changes. So essentially, an individual gets a blow to the head or the body that causes the skull to rapidly decelerate, but the brain continues to move within the skull. This causes shear forces, which stretches the axons, resulting in damaged axons and a whole host of neurophysiological deficits. Concussion is a form of traumatic brain injury, so it is on the TBI spectrum, but it is on the very, very mild end. So we're talking about the mildest of the mild MTBIs. Concussion is a significant public health and societal concern in Canada. Essentially 1 in every 70 visits to pediatric emergency rooms are for concussions. So if you think about all the reasons why a child might go to an emergency room for, illnesses, broken bone, chronic disease, every 1 out of every 70 visits are for concussion. And this results in a number of different negative outcomes for the child. It means they're often forced to miss their sport in school. It results in a host of mood and emotional related disorders, and overall it reduces quality of life. So appropriately diagnosing a concussion is a key first step to ensure a positive outcome. So we know that concussion results in a number of different symptoms and functional deficits, which you can see here on the screen, things like cognitive problems, migraines, visual vestibular deficits. And there are a number of clinical tests currently within each of those domains that we can use to sort of assess and measure outcomes. However, despite this wide variety of deficits that patients may experience after concussion, really only symptoms, cognitive, and balance testing are what is sort of considered best practice. So a lot of these other domains are not even regularly assessed or treated for. When a concussion is diagnosed, there are different forms of treatment or active rehabilitation, which is available that can help reduce these clinical deficits and can help whether the intervention is applied within a few days of injury or several weeks to months following injury. So aerobic exercise, which I will talk about quite a bit, is one of the most common forms of treatment after a concussion. There are also some more focused treatments on the specific deficits. So individuals with mood or cognitive disorders might benefit from neuropsychological treatment. Ocular disorders might benefit from some visual training. So exercise and these sort of active components are really the core of treatment currently. Over the last 20 years, there has been a major increase in the amount of research done for concussion, and this has resulted in a number of improvements, both to our diagnostic tools as well as our management and treatment approaches. But currently, our treatment and our management is insufficient to have everybody completely recover. So roughly 30% of all children and almost half of all adolescents will experience persistent symptoms. So typical recovery time in children is about 4 weeks. So nearly half of adolescents are remaining symptomatic for several months following injury. In addition, we know that even once a child clinically recovers and all of their symptoms and problems from that current concussion goes away, they are at higher risk of future injury. So this includes repeat concussion. It also includes things like musculoskeletal injuries. And there is some emerging research which continues to show that there are physiological deficits after concussion, and they persist beyond this clinical recovery. However, we still don't know what the time course for this physiological recovery is, or whether even an individual ever fully recovers physiologically from a concussion. So right now, current concussion diagnosis and management is really focused on these clinical outcomes. So when a concussion occurs, an individual is diagnosed based on their clinical deficits and findings. These more broad generic forms of treatments focused on their symptoms and their deficits are prescribed. However, these treatments are insufficient and subtle physiological impairments still remain. This increases risk for injury, and then an individual might experience a repeat injury, and the cycle continues. So the rationale for my research, or sort of the central hypothesis that I have, is that by linking these functional and physiological outcomes together, we can maximize both this clinical recovery, but also physiological recovery, and really help patients have a more lasting improvement. So my research seeks to evaluate clinical and physiological deficits to diagnose patients. Once a concussion is identified, I'd like to apply personalized treatments that focus not only on the clinical deficits, but also on the specific physiological impairments that a patient presents with. Hopefully, this will promote full clinical and physiological recovery, and then an individual will be at no increased risk of injury. So that's not to say that nobody will ever get hurt again. It's just that their risk of having a repeat concussion or a musculoskeletal injury is the same as any other child who's never had a concussion. So the overarching goal of my research is really to promote full recovery from concussion by developing non-pharmacological interventions that maximize clinical and neurophysiological functioning. And my research and this overarching goal is really broken down into two research lines. The first is using EEG to really understand what are the deficits that patients with concussion are experiencing. Can we use EEG to find a biomarker of injury? And then how does this EEG, or how do these physiological outcomes relate to clinical impairment? So what is really the physiology that's underlying clinical presentation? And then once we understand that, my research seeks to create personalized active rehab programs that target both these clinical and physiological deficits to eliminate any dysfunction, reduce the risk of having these long recoveries, and to prevent future injury. So we'll first focus on this initial research line, looking at some of the work that I've done with EEG and some ongoing work in that area. So as I mentioned, we have a whole host of clinical diagnostic tools that are currently available. However, they're limited by a number of different factors. They have practice and learning effects. There's poor reliability. They have really low sensitivity. In fact, there's been some studies which suggest that individual tools have sensitivity as low as 6 to 25%, and that a combined battery of tools is only 50% sensitive to concussion. So we're misdiagnosing or underdiagnosing a lot of injuries. In addition, many of our current clinical tests are subject to participant manipulation. So a lot of these are subjective and self-reported. So individuals can essentially lie or cheat the test to get the outcome that they want. This is especially problematic with athletes who want to go return to play as quickly as possible. So I think EEG is a novel way to assess for concussion, and it addresses a lot of these limitations. EEG generally has good reliability. It can't be manipulated or cheated. Now we just need to see, is it sensitive and specific to this injury? In addition, EEG is also looking at that underlying neurophysiology instead of just measuring the functional deficits. So one of the first steps in my research here was to figure out what's been done in the literature. So we did a systematic review to see if EEG, if there's any evidence to support the use of EEG in clinical settings. So roughly 800 articles were screened and ultimately only 13 were included, which tells you just how little research there is in this area. Our systematic review highlighted two main findings. The first question that we wanted to know is what EEG features are related to clinical presentation. And of our 13 studies, only 2 of them directly compared EEG and clinical presentation, and there was no consistency across these studies as to what EEG features were used. The second question we asked was, does EEG have any clinical utility? Can it assist in diagnosis or management in any way? And the current literature suggests that this may be possible, but none of the research has been done in clinically relevant timelines or clearly associated with clinical outcomes. So essentially, the research has just been taking people with concussion across, several days to weeks to months to years post-injury, getting an EEG, and just that's it. So there's been no real tie or relationship to how this can be used clinically. So my research aims to fill these gaps by determining which EEG features are best to use for patients with concussion, how we can relate EEG to clinical presentation, and to conduct these EEG assessments at clinically relevant time points and in clinically relevant settings. So I'm going to take a moment to explain a couple of the features that I've been looking at, or some of the different EEG analyses that I use, just to provide the basis and foundation for some of the upcoming slides. So my research over the last few years has really shifted to looking at functional connectivity and graph theory analyses, which are largely unexplored in patients with concussion. So most EEG research, including some of my early graduate work, focused on spectral outcomes. So spectral EEG analysis essentially quantifies the oscillatory power of the brain's electrical activity across varying frequencies. So essentially, it treats each electrode as independent. So the electrical activity picking up from that electrode is analyzed separately from that of the other electrodes. But when you think about concussion and you consider the fact that it's primarily damaging axons, and we think about how axons are responsible for communication in the brain, something like functional connectivity could be more interesting or make more sense, because functional connectivity measures the synchronization of neural activity across electrode pairs. So it basically takes the EEG signal from pairs of electrodes, compares how similar the signals are, with the thought that the more similar the signal is, the more likely those areas of the brains are sort of connected or communicating together. And then graph theory is essentially a way to synthesize or summarize the functional connectivity matrix into a graph representation. And it allows us to look at the brain as a network. So it looks on a network-based level as opposed to sort of an electrode-based level. So 2 of the functional connectivity analyses that I use quite frequently is weighted phase lag index and the amplitude envelope correlation. So the weighted phase lag index, or the WPLI, looks at whether 2 electrodes have a phase leading or lagging relationship. So if we think back to our high school math, we know that a circle has 360 degrees. Essentially, the peak of the amplitude is 90 degrees, the trough is 270 degrees. So when we look at WPLI, what we do is we take 2 EEG signals and we compare the phase angle for each of those signals. And the goal is essentially to see whether one electrode, the phase angle is consistently in front of or behind the second one. So if we look at our signals here, for example, if we take this data point, the black dotted line is at a phase angle of 180. The teal line is at 90 degrees. So the black line is phase leading the teal line in this example. And essentially, we take this information and eventually it just gets summarized into a single data point where WPLI takes on a value between 0 and 1, 1 being a very strong connection, a very functionally coupled relationship, and 0 means there is no connectivity. Another metric we can use to calculate functional connectivity is called amplitude envelope correlation, or AEC. This one, instead of looking at each of the 2 signals oscillations on their own, A Hilbert transformation is used to create an envelope above the signal. That's the line that you can see in pink. And then Pearson's correlations are computed between the envelopes across all combinations of electrode pair to see the relationship between that pair. Essentially, it's just a different way of ending up with the same 0 to 1 value, where 1 again is a strong functional relationship and 0 is no connectivity. So with this background in mind, we collected some pilot data. We did a resting state EEG on 13 adolescents with concussion. They were tested within 10 days of their injury, and they were all symptomatic at the time of testing. And we compared them to 43 healthy children using these functional connectivity and graph theory outcomes, as well as a number of other EEG features. This is a picture of the headset that we used. It's a really nice, portable, translatable. It's quick to set up. It takes about 5 to 10 minutes to put on. So it's a really nice, neat little system. And all of our patients were tested during a clinical visit. So we work with the Montreal Children's Hospital Concussion Clinic. Essentially, when patients were eligible, we would pop over at the end of their visit, put on the EEG. It took about 15 minutes, and then got them out the door. So there were no additional visits or trips back to the hospital. And the fact that we could record data in a clinical environment just speaks to the feasibility and possibilities to integrate this technology into clinical practice. So this is some functional connectivity data for single participants. So on the top, we have a single healthy participant, and on the bottom of the screen, we have a concussed participant. Each of the gray circles represents one of the 19 channels on the electrode. We have sort of a top-down view in the middle, and then we have the left and right views on each side. And we can look at functional connectivity dynamically, meaning we can take these little 10-second chunks of window, 10-second chunks of time throughout our resting state analysis, and we can look at how the functional connections change. So anytime you see a line connecting 2 of the gray dots, it means there's a functional connection between those electrodes, and the more red or the warmer the color is, the stronger the connection. So you can get these really fun graphs that look at how functional connectivity changes over time and how dynamic the brain is, but it's kind of hard to interpret a lot of patterns with this. So we can also represent functional connectivity in a matrix. So in this case, each of the colored squares here represents the strength of a functional connection between 2 electrodes. The electrodes are organized. So you'll see on the bottom of the screen, the F stands for electrodes in the frontal area. Then we have the central, temporal, parietal, and occipital. And then again, the color represents the strength of the connection, where stronger functional connectivity is warmer or more red colors. So you can just visually see that children with concussion have decreased functional connectivity across the board compared with our healthy children. And you can also notice some differences in the patterns or the regions where these differences pop out. So our healthy children have really strong functional connections in the frontal and central areas of the brain, and that's the strongest connections across their matrix. The children with concussion, while they have lower connectivity across the board, their strongest connections seem to be more in these parietal and occipital areas. So it's some just really interesting findings about how functional connectivity is different between these groups. Beyond functional connectivity, we did look at a whole host of metrics. So we have spectral metrics on the top, looking at power and peak power. We have permutation entropy, which is a measure of information content in the signal. We have our WPLI, AEC, and DPLI, which are functional connectivity metrics. And then here we have path length, which is one graph theory metric. In the gray, we have our healthy participants, and then the different colors represent our concussed group. And we saw that spectral, entropy, functional connectivity, and graph theory metrics all differed between these groups. So just across the board, there seems to be a lot of different metrics that can separate children with concussion from healthy children. But we wanted to take this a step farther and see how well EEG could separate these groups on their own. So we looked at receiver operating curves, and on the left side of the table, we have our different EEG metrics Then we have our sensitivity, specificity, area under the curve, and p-value. And we found that spectral power, particularly in the delta frequency band, was a really strong classifier of concussion. It was 100% sensitive and 93% specific, with an area under the curve of 0.97. Not very far behind, we also had AUC. We had our functional connectivity metric, which was 92% sensitive and 83% specific. So this is some quick and dirty pilot data that we have, but it is providing some preliminary evidence that EEG can pick up these deficits and can separate children with concussion from healthy controls. So we have some funding that we got recently from CIEHR to look into this in a little bit more controlled way. So our next steps here is really looking on, we're getting a larger sample size of concussed children and healthy children. So we're looking to recruit 48 children in each group. They will both come in and complete a resting state EEG, as well as a battery of clinical assessments within 10 days of the injury. Then again, at 1 month post-injury, which is again, that sort of typical recovery time for children. And then we'll do a long-term 6-month follow-up. And our goal here is really to determine which EEG features, if any, have potential to be clinical biomarkers of concussion diagnosis and prognosis. Then looking more longer term, where this research will hopefully go in the future, I'm interested in trying to make this even more clinically translatable and feasible. So that means accessing and testing patients within a variety of different clinical settings. I'm interested in looking within the emergency department, within, on the sidelines of athletic events, in athletic training rooms. So really expanding to see whether we can use this in a more clinically feasible way, as well as expanding to multimodal imaging platforms. So concussion or EEG will always be sort of a central modality in my research because it has this potential for translation, but there's a lot of different physiological systems that can be disrupted following concussion and that we can look at in many different ways. So I'm interested in doing some EEG MRI work, as well as EEG and some FNIRS work to get a more complete understanding of what systems are disrupted following concussion. So transitioning over to the second area of research, which really focuses on active programs to help eliminate post-injury deficits and to reduce the risk of prolonged recovery. So a lot of the work in rehab with concussion comes from a very clinical physiotherapy kind of perspective. And the rationale is essentially that by doing some form of active rehabilitation, we're taxing these physiological systems that might be disrupted. And by adding some sort of stressor or by taxing these systems, the systems can then recognize that there is an error or that some level of dysfunction is occurring. Once that error is recognized, the system can produce adaptations to correct these errors, to correct this dysfunction. This ultimately reduces our clinical deficits, and essentially it enhances recovery. So that's sort of the big picture goal here. And the way that's applied to concussion most frequently is through active rehabilitation programs. So we know that concussion causes a lot of dysfunction neurometabolically, to cerebral blood flow, to autonomic nervous system functioning. So essentially, rehabilitation kind of taxes those systems, and exercise can be effective and safe at sort of promoting recovery from that perspective. However, while exercise is safe and while it's generally effective, there's really no consensus on how to prescribe exercise or what that prescription should look like, which is really problematic because there's a lot of healthcare providers who are unwilling to prescribe this treatment because they don't know how to, or they're uncomfortable with what the parameters should be. And that's reflective in a systematic review that we've done, looking at all kinds of exercise and active interventions in concussion and mild traumatic brain injury populations. And we found that there's really a ton of variability. The frequency of these programs are prescribed anywhere from 3 days a week to daily, or even more than once a day. The duration of these activities range from as little as 5 minutes all the way up to an hour. The intensity of the prescription can be prescribed through heart rate or just based on a person's perception of difficulty. So basically, there's a ton of variability here, and my research wants to evaluate the different parameters of post-concussion exercise prescription to try to determine the optimal program to help promote recovery. And an important part of prescribing exercise for patients is knowing what the right intensity is. And oftentimes we use progressive exercise tests to determine that intensity. So essentially you start a patient off with a very low intensity and you keep ramping up that intensity at set intervals, essentially until an individual with concussion becomes symptomatic, because about 95% of individuals with concussion who are symptomatic are exercise intolerant. So they cannot go to maximal exertion without experiencing symptoms. So this is a method that works quite well, but the problem with COVID when that occurred is that we couldn't get patients into the clinic. So most patients don't have a treadmill or a stationary bike at home, so there was really no way to safely and effectively prescribe exercise during the pandemic. There was no virtually compatible system. So we created a protocol called the Montreal Virtual Exertion Protocol, or the MOVE protocol. That's basically a plyometric at-home telehealth compatible exertion test. And we tested it out in 20 healthy children and 30 children with concussion to see if it was safe and feasible. So all 20 healthy children completed the MOVE protocol, which was the new protocol we designed. For children with concussion, we had them randomized either to the MOVE protocol or the BCTT, which is the Buffalo Concussion Treadmill Test, which is basically the gold standard for concussion exertion testing. The MOVE protocol consists of 7 different stages of exercise. Each stage lasts for 60 seconds, followed by 60 seconds of rest. The stages include walking in place. There are 3 jogging stages. So it's a slow jog, a medium jog, and then a fast jog. Jumping jack exercises, high knee exercises, which is essentially running in place, but your knee comes up to a 90-degree angle with your hip. And then quick step exercises, which is basically sort of running or tapping your feet in place as quickly as possible. So as I mentioned, each stage is 60 seconds long, and then there's a 60-second rest period, which allows us to collect our outcomes of interest during that time, which includes heart rate, measures of perceived exertion, so how difficult did the children think the exercise would be, as well as their overall symptom scores. This is a visual analog scale from 0 to 10, where 0 is absolutely no symptoms, and 10 is terrible, the worst they ever felt, all the symptoms in the world. So firstly, and most importantly, our new protocol, the MOVE protocol, met all definitions of safety and feasibility. There were no adverse events reported throughout the protocol. We could test them virtually, so we didn't have any internet issues or connectivity. It could be implemented. Importantly, we tested kids as young as 5 years old, so it was a good check too that the exercises we chose were, feasible for young kids as well as adolescents and older children as well. We also looked at their heart rate using both manual pulse and heart rate monitors, and they were similar between both. So there were no significant differences in the heart rate between the groups or the different protocols. Similarly, all of the protocols produced an increase in rate of perceived exertion that was similar across the group. So everyone thought the exercise got more difficult as it went on, which it should have. And importantly, there were no meaningful changes in symptoms for either group as well. So essentially, we found that it's safe, it's feasible, it works, and we're hoping to implement this more broadly, especially for clinics, even if you're in person, that might necessarily have the space, the funds, or the resources to have large pieces of equipment like treadmills. So for the last couple of minutes, I want to sort of bring this back to the big picture, which I've talked about exercise and I've talked about EEG, but I'm really interested in the integration. And that's kind of the overarching goal, which is to promote recovery by sort of maximizing and integrating clinical and neurophysiological outcomes. So one of the most exciting things to me looking forward is the way that EEG can aid in the development of post-concussion rehab interventions and how they can evaluate their effectiveness. So essentially, if we can pick up these neurophysiological changes on EEG, can we design targeted personalized treatments based on these physiological deficits? And can we use EEG as an outcome measure to see after these interventions if we've actually created change or rehabilitated these systems? So a lot of work has been done separately, but now the focus is on how we can sort of combine these two activities to really maximize recovery. So I was part of a study during my master's degree that recorded EEG during a stationary cycling task. So we looked at the effect of EEG on, or looked at the effect of exercise on EEG in recently concussed athletes. So it's important to note that all of the athletes tested were Division I college athletes. They were within 10 days of their concussion, but they were all clinically recovered at this time. So they were fully returned to their sport. They had no symptoms and no observable deficits on any clinical metric. We used 128 channel EEG and we recorded it before, at rest before the exercise. We recorded it throughout the exercise session. We recorded them at rest again immediately after the exercise. So seated quietly right after getting off the bike. And then we had them come back to the lab 24 hours later where they completed just another seated resting EEG. So the results here are shown just for delta power in particular, but we had very similar findings across all frequency bands. So we have at the bottom condition refers to whether it was pre-bike, during bike, post-bike, or 24 hours later. Our groups on the bottom, NV is our normal volunteers or our healthy controls, and then our MTBI group. And the regions just correspond to frontal, central, or posterior regions of the brain. And you can see for the condition 2 and 3, so during the bike and immediately post-bike, both groups had increases, but the concussed group had a much larger response. So they had significantly increased delta power during the bike and immediately after. However, there were no group differences at rest, pre or 24 hours later. So we hypothesize that this increased power in the concussed group may be related to changes in cortical blood flow and oxygen metabolism, which we know are disrupted following concussion. And lastly, some of my PhD work was looking at exercise interventions and how that can affect EEG. So beyond recording EEG during a single exercise session, what about if we do a brief training intervention? How might that affect EEG outcomes? So all of our participants here were healthy controls. They were non-injured. Unfortunately, we just didn't have, it was not feasible to get this data in patients with concussion at that time. So all of our healthy patients came into the lab and completed a resting state EEG, a whole battery of clinical assessments, and then they completed a maximal exercise test. 2 weeks later, they returned to the lab and basically completed the same battery of tests over again. The 2-week intervention period was chosen because 2 weeks is the typical recovery time for adults with concussion. So even though we were testing in healthy patients, we tried to make the time frame as clinically relevant as possible by approximating typical recovery times. Between these 2 test sessions, participants were randomized either into the active training, which is our intervention group, or the control group, which received no intervention. So the active training group, I'll talk to them. I'll give you a little bit more information about that prescription, but they basically were randomized to do some exercise, and both groups wore a Fitbit throughout, so we could kind of monitor physical activity levels throughout that intervention period. So this is the protocol for the maximal exercise test that we use. I'm not going to go into it in too much detail. There's a bunch of different prescriptions or graded exertion protocols you can use. But the important thing was that for the individuals randomized to the exercise group, the graded exertion test helps set the intensity of the protocol. So essentially our active training group, they completed a stationary cycling protocol. So essentially they came back to the lab 3 days a week, which because it's a 2-week intervention period, it corresponded to 6 sessions. So participants came back to the lab, they did stationary cycling on the same bikes that they did their maximal exercise test on. The duration of each session was 30 minutes long and the intensity was progressive. So basically session 1, they started out at 60% of the VO2 max that they achieved during their first maximal exercise test. And by the 6th and final session, they had progressed up to 80% of VO2 max. So they were training at the level equivalent to 80% of VO2 max. So we assessed 45 participants for the study. 40 of them were randomized, 20 within each group, and there was no loss to follow-up. So when looking at the EEG outcomes, the dark blues on the left are our no training group, and on the right, our teal group is the training group. On the y-axis, we have alpha power, particularly in sort of the central regions of the brain. And on the left, we have the pre-intervention and then the post-intervention towards the right. So we have our violin plots looking at the density or the distribution of the data. Each black line represents an individual participant's change from pre to post-intervention, and the red line looks at the group averages. Essentially, we found that there were changes in the central alpha power pre to post intervention in the exercise group only. So if we look at our no training group in the dark blue, we look at that red group average, it's basically a straight line, there was no change. But when we looked at our training group, we see a significant increase in central alpha power over the course of our 2-week intervention. And we wanted to take this one step further and see if these changes were related to any sort of clinical outcomes that we collected in this study. So on the y-axis for all 3 of these graphs, we have that change in central alpha power. On the left, we have the GAD-7, which is a self-reported anxiety scale. In the middle, we have the PHQ-9, which is a self-reported depression scale. And on the right, we have symptoms, which is essentially a generic self-reported post-injury symptom score. So while we found no change or no differences in total symptom scores, we have 2 very straight parallel lines all the way on the left. When we look at self-reported anxiety and depression, we see that in the intervention group only, in the, looking at the teal dots and the teal lines, there was a moderate correlation. Both of them were, the correlation was about 0.45. So essentially, the bigger the change in the alpha power, the bigger the decrease was in the self-reported anxiety and depression. So these are some really interesting preliminary findings that we're hoping to explore with some future work. And speaking of that future work, our next steps in this research are really focused on determining how these different EEG metrics, especially the functional connectivity and graph theory features, change in response to exercise. So it's really about finding these neurophysiological targets that can separate concussed and healthy participants, and then seeing how exercise can be used to modulate those same targets. And our goal here is really to try to understand the mechanisms underlying exercise intolerance in individuals with concussion and how exercise training can modulate these outcomes to hopefully promote not just clinical recovery, because we know that exercise promotes clinical functioning, but can we also use exercise to promote better neurophysiological recovery? So this study is going to look at 48 participants, 24 with concussion and 24 healthy controls. All our participants, healthy and concussed, will complete a graded exertion test. An EEG will be collected seated at rest beforehand, as well as throughout the exercise protocol, to try and understand the physiological mechanisms driving post-concussion exercise intolerance. So they'll also be given a battery of clinical assessments that we can also try to relate the EEG to as well. This is the protocol for the exercise test. So we have a slightly different progression for males and females, just to try to make the total time of the test a little bit more equivalent. But essentially, individuals will do their resting state EEG, will get information about their post-injury symptoms, We'll fit them with a heart rate and explain the exercise testing protocols. They'll complete the exercise test, and we will collect heart rate, symptoms, and rate of perceived exertion every minute throughout the test. And then once the exercise is done, they'll complete the clinical battery in a randomized order. So that would conclude participation for our healthy participants, but for our individuals with concussion, the same 24 patients will be randomized to one of two exercise prescriptions, either a standardized prescription or a flexible prescription, which they'll follow until clinical recovery. So every week they'll virtually check in with a research team member to modify their progression, their exercise prescription as needed. They'll also complete some logs to help track the exercise perform and any adverse events. And then once they are recovered, so once their symptoms are gone, once they're back to school and back to sport, they'll repeat the same battery of tests, including the exercise test at that time. So the standardized exercise prescription is just a rigid protocol that was based on effective prescriptions found in the literature. So participants will be asked to walk or run on a treadmill or cycle on a stationary bike 5 days per week for 30 minutes per session. So a total of 150 minutes of activity per week. And the intensity will be based off of their initial exertion test completed in the lab. Every week we'll progress the prescription, and essentially the only factor that's changing is the intensity. So the mode, frequency, duration will be consistent across the protocol, but it will become more intense as tolerated over time. Conversely, individuals in the flexible exercise prescription will perform the same 150 minutes of activity per week, but they'll be able to largely choose the manner of their activity. So there will be some restrictions in place for safety, but otherwise individuals are asked and will work with the research team to create their own exercise prescription using different modes and durations that are of interest to them. So the parameter, participants will be allowed to do any exercise as long as it doesn't have strong vestibular demands, because we don't want to increase their symptoms terribly. They'll be allowed to do up to 2 sessions per day, up to a total of 45 minutes of activity per day. And the intensity will be chosen by the participant based on their symptoms. So using this 0 to 10 visual analog scale, participants will be asked to rate their symptoms at the beginning of exercise. As long as the exercise, if it doesn't change their symptoms, they can keep going at that intensity or increase it a bit. If the exercise starts to increase their symptoms a little bit, they'll be asked to reduce the intensity. But if the symptoms change greater than 3 on this 0 to 10 scale, then they'll be asked to end their exercise for the day and try again tomorrow at a slightly lower intensity. And then they will also progress every week by meeting with a research team member to create adaptations. They'll be able to add exercises with vestibular demands, so things like swimming or dancing. The duration can go up to 60 minutes per day, and the intensity will still be based on symptoms. So it will likely increase as participants continue to recover, but there won't be any, set increase. It's based on participant preference. So longer term goals for this research is really focused on creating more multimodal interventions. So I think exercise is important because it's very feasible. It's globally useful. Most of the clinical domains that exist following concussion can benefit from physical activity, but participants often will need more than just exercise. So looking into adding things like visual and vestibular training, looking at balance or cognitive activities, adding neuromuscular training components to reduce future injury risk, as well as altering the exercise parameters on their own. So incorporating things like interval training, high intensity training, or things like resistance training as well. Additionally, something I really am excited and want to explore in the future is looking at neuromodulation. Again, the goal is to see what physiological systems are disrupted following concussion and how we can actually alter and change the neurophysiology. So neuromodulation provides a great opportunity to actually modulate more of the physiological systems that are involved. So I'm interested in looking at things like TACs, closed loop auditory stimulation. There's a bunch of different options that I'm hoping to explore over the next few years. So to wrap everything up, EEG can measure the neurophysiological consequences of concussion. EEG can pick up dysfunction after concussion. And I believe that this technology has the potential to elucidate potential biomarkers, both diagnostic and prognostic biomarkers. It can characterize the different changes and neurophysiological systems and how they relate to clinical presentation, as well as to evaluate the effectiveness of rehab interventions to promote recovery. We know that rehab on its own can improve quality of life with patients with concussion. It can reduce recovery time, it can reduce overall symptoms. So it has the potential to eliminate these immediate consequences or the immediate deficits patients experience after injury. It can restore pre-injury functioning along faster timelines and prevent persistent symptoms. But I think really where the future is and what the most interesting part is really this integration. And I think if we can use EEG to measure what is going on in the brain and what's disrupted after concussion, and whether we can create rehabilitation platforms that directly target that physiological dysfunction, that is the part that I think has the highest potential to improve clinical care for individuals. So by integrating these outcomes, we can create more personalized rehab programs that eliminate both clinical and physiological deficits to promote complete recovery and reduce future injury risk. So all of the work that I've presented here is work that I've done throughout my postdoc and my graduate work. So I need to say thanks to my postdoc supervisors, Stephanie Blaine-Moraes and Isabel Gagnon, as well as my PhD lab at the University of North Carolina at Chapel Hill. Have a brief, this is all my funding disclosures. And thank you, everybody who's come, who's attended, who's listened, and I'm happy to answer any questions at this time.
Thank you very much, Dr. Teel. That was a great talk. We do have several questions, all from Christoph Grova. We're not too many attendees at this point. So Christoph, I could read your questions, but I'm also going to allow you to talk if you would like to pose them directly to have a discussion with Dr. Teel herself. So I have unmuted you. If you want to go ahead, Christoph.
Can you hear me?
Yes, we can.
Okay, thanks a lot for the excellent talk. Yeah, I do have several questions. We should not address them all, but I would like to perhaps have your point on why did you use this? I guess it's a system based on dry EEG electrodes, and how did you assess EEG quality? And I would say my second main questions would be on the fact that when you are using functional connectivity based on the EEG, so you did it from the scalp.
Mm-hmm.
And there are some pitfalls in doing so. So I wanted you to comment on that and whether you consider using it in the source space after applying source imaging.
Right. Those are both great questions. So a lot of what I'm trying to balance with that particular system is this idea of widespread clinical translation. So by using systems that use dry electrodes, we've really cut down on the time it takes to put the cap on and to record data. But that, as you mentioned, it does come with some limitations and pitfalls. So the reason we use the particular system that we use is, as I mentioned, my former supervisor, Stephanie Blaine-Moraes, she has done a lot of testing comparing wearable EEG headsets to a 128-channel EGI research grade system. And the system that we use is very similar and very comparable. So yes, it's not quite as great quality, but we've looked at spectral and functional connectivity outcomes, and they're very equivalent between the two systems. So you certainly do lose a little bit of the EEG quality, but there is some evidence and there's some research to support that you're still getting a fairly decent quality signal, and that, you know, the system that we use is providing good data specific to the metrics that we're using. And like I said, it's that balance between the clinical integration. So we can set up the EEG system and record data within 10 to 15 minutes, which does make it feasible for things like, in a clinical setting, in an emergency department, in a sideline. So some of my other research will incorporate much more high density stuff, but in terms of thinking about translation and systems that can provide something in a clinically meaningful sort of point of care type of way, this is kind of the balance that we have to strike. In terms of the functional connectivity question, yes, I would be interested in looking at more of some source-based stuff. And I have worked with some source localized data before as well. As you're well aware, when you have 19 channels, you can't really source localize. You need much more dense EEG systems. So that is something, as I start to work in the Perform Center and use the high density system, it is something that I'm interested in looking at functional connectivity, both from a source space and from a scalp space.
Okay, thank you very much. Perhaps another comment on that. I'm not so sure, like depending on the finding, you're not trying to find like so localized activity here. So there might be some ways to do also source imaging with very few electrodes to see what's there, because it's going to remove some of the leakage. And I think that's like I think this is not so clear, especially for resting state functional connectivity of this slowing, which is probably quite widespread. And I don't know, but that's something to be investigating. Last, just to know, when you mention amplitude envelope correlations that you're using a lot, you did not mention in what frequency band you use that, just to get an idea.
So we use delta, theta, alpha, beta. So most of our work doesn't go up to gamma for a couple of reasons. Part of it is just the labs that I've trained in haven't really explored that. So there wasn't a ton of expertise to go help with the interpretation of data. The skull also acts somewhat as a natural filter when you get in higher frequency ranges as well. But for all of, from delta through beta, we've used AEC on all of them. So just like the other outcomes, you sort of filter by frequency band, and then you can run the analysis on each of the individual frequency bands.
Mm-hmm. Okay, thank you very much. Again, it's a great talk, and let's discuss soon, because there are a lot of things we can probably do here at Perform for that.
Yeah, I'm very interested, especially, as I said, we know that blood flow is disrupted after concussion. So especially with your expertise in FNIRS and how we can look at maybe some blood flow and oxygenation in combination with more of the electrophysiology could be a really interesting avenue in the future.
Yeah, there for sure. Yes, as well. Okay, I'll stop there.
We have a couple other questions. Christopher Steele also has some questions. Christopher, when you're ready, you can unmute yourself.
Great, thanks, Wendy. Thank you very much for that really nice talk there. We'll echo Christoph's comment that was really nice, and it's really, really interesting and exciting work that you're doing. So so my lab does quite a bit of structural imaging, and I just wondered if, I have a couple of questions, so maybe I'll just start with the first one. I'm just wondering if in the field and you yourself have considered incorporating structural imaging techniques into some of these assessments.
I know there is work being done in the field more broadly. It's not exactly my area, so I don't have a ton of information, but I know there is a lot of work that exists. I have not done it, and mostly it's been a limitation or a result of sort of the places that I've trained and the expertise that I've had the access to. So I'd certainly be interested in exploring it in the future. I have a couple colleagues and collaborators who also do structural imaging, but I personally have not done it myself just because I haven't had access to the equipment or the help to train on how the analyses are performed.
Yeah. So it just sort of struck me, like in the beginning, of course, you were saying that, one of the major impact of the concussion is on the white matter. So you could think that actually looking at white matter differences or white matter changes, if you have a prospective study, could give you a little bit more insight into the pathological changes that are occurring, or the
So there's definitely been some DTI work done. I know Dr. Benali and I talked as well during my interview here about sort of DTI and other types of structural imaging. So there's certainly an interest. It's just something that I would very much need collaborators and assistance, because it's not something I'm capable of doing on my own.
Well, our lab's here, so be happy to talk more about this. Another, related-ish question here is sort of towards the end, where you were talking, I think it was about a prospective study, where you were talking about like potentially deriving these personalized interventions for different, different, I guess, different patterns of behavioral deficits, or different patterns of EEG-based differences that you identify. I think this is a really nice area, and obviously something that's gained a lot of traction in the last 5, 10-ish years, right? This sort of personalized medical interventions area. And I think one thing here, also keeping to this structural idea, one thing here that I think could be potentially really useful for this type of an approach is to think about the regions that are affected and their connectivity based on their structure as well, right? And then this gives you some idea if, for example, if the location of the concussion is, you've got your coup and your counter coup, and the location of the concussion, most of the damage is frontal, then maybe part of the intervention has to be some sort of cognitive intervention as well.
Yeah, totally. Part of it goes to Christoph's earlier point about looking sort of at scalp level functional data. We're not, the information we have right now is not really looking at specific structures of the brain, which is why some of my interest in the future is looking at source localization and doing more multimodal work. But I totally agree. This is kind of where we're at now, and this is the starting point. But, the overarching goal really is to let's figure out what systems and what areas, what regions of the brain, what specific structures are disrupted, and how we can provide treatments that are targeted to that. So I completely agree that it would be a benefit and would make more stronger personalized approaches available.
Cool. Yeah, I'm happy to talk more about that offline as well. My final question here is around plasticity. So, I guess it's kind of two questions in one. So athletes, or I guess it's, partly. Anyway, if you have athletes, if you're looking at, professional athletes or university-based athletes, and those are people who are training in specific tasks for multiple hours per week, or potentially multiple hours per day, right? So you have some definite structural, functional, plastic changes that are occurring in those individuals' brains. And then when you have them have a concussion, or when they unfortunately experience a concussion, and then they have some sort of a recovery after that, can you compare that directly to an individual who is not a professional sports person? That's sort of one part of the question. And then the other part of the question is how much, that's the question. We'll stop there. Sorry.
Yeah, it's a good question. And can you? Yes. Should you? is a different
exactly.
question. I think it very much depends on the population you're looking at. Typically, if we're working in more elite level sports situations, we try to recruit from the same team, and that's where we try to get our match controls from. That's the best option. Sometimes it's not always feasible. So then our next step is let's try to find a sport that's in the similar kind of category of contact versus non-contact, or more like endurance versus more sort of power sport. But yeah, there are definitely some changes that are gonna affect things. So we try as best as possible with, college athletes and pros to match them directly within their own team when possible. I think when you're working with kids, it's a different story because they're not training as long and as hard, and the changes that you're talking about are like the neuroplastic changes are probably not as specific. With kids, there's been some research to say that, orthopedic injury controls or healthy controls perform similarly. So I don't think you're quite as restricted in kids. It's really once you get to the elite levels where you might want to try and match more closely.
Great. Well, thank you very much. And also really, really nice stuff. Welcome to Concordia.
Thanks.
Okay, we have one last question from Habib Ben Ali.
Yeah, thank you, Wendy. Do you hear me?
Yes, we do.
Okay, so thank you very much, Elizabeth. It's a very nice talk, very interesting talk too. I have a couple of questions. So my first question comes with the fact that concussion it's a huge problem, as you know, because it comes with a lot of variability between the patients. So localization of the concussion is different from one patient to another patient. So what do you mean by averaging? I mean, a group data analysis, when you compare between healthy subject and concussion contain a lot of variability. And whatever the modality that you are going to use, EEG or another modality. So do you think that you have to focus yourself on the individual data analysis for each patient compared to healthy, for instance? Or do you think that the group data analysis means something?
Yeah, I think it depends what the application is. So if we're talking about developing very personalized treatments, then it obviously needs to be at the individual level. There certainly are limitations to group-based analysis because, as you mentioned, there's differences in where, like what part of the brain is injured, but there's also differences in clinically how they're presenting. The problem is we don't have a lot of great tool. There's not really a concussion subgroup. There's no existing data, either from a clinical standpoint or from an imaging standpoint, really to help us bin patients into these kind of tighter groups. I think it also depends on sort of how you want to generalize your results when we're talking about, or when I'm thinking about EEG biomarkers. You're just going to get a kid and you're not going to know what region of the brain is. So there might be situations where you're going to have to come up with, different features or different algorithms that respond to different types of injuries or different areas of the brain. So that's kind of what my work is hoping to get at by looking or trying to relate EEG to clinical presentation to see if we can find some information about certain types of features in certain areas of the brain being linked to some sort of clinical presentation or functioning. So I think, right now we're doing the best that we can and we don't have a lot, but I hope in the future as we start to learn more and we start to figure out what these sort of different neurophysiological disruptions are, we can start creating kind of subtypes that would help us figure out what deficits people have and how to more appropriately treat those specific deficits.
Okay, thank you. Another aspect who is related to what I said before is the fact that you focus on features that you extract from EEG. And I am wondering, with concussion, which is, from my point of view, mainly related to this disruption between the neurovascular coupling. So my question is, I'm not saying that EEG cannot give some information about the concussion, but it seems to me like if I focus on a more vascular technique or technique who include more vascular compartment like optical imaging or the nerves, which can be used exactly the same way that you use the EEG. So this is like a setup that we have at the Perform Center, but dedicated to this neurovascular coupling or including this neurovascular coupling. Do you think this kind of modality can help more or can get more specific biomarkers for concussion?
Yeah, certainly. So this is something that Christoph and I have been sending emails back and forth about, trying to find a time to discuss. Because as you said, there certainly are cerebrovascular deficits that occur after concussion. There's a host of them, right? So cerebrovascular is one. Like, we know the autonomic nervous system gets disrupted. We know that there's neurometabolic changes. So I definitely don't think it hurts to add. My focus on EEG, like I said before, is largely the focus of where I've been, what equipment I've had access to, and what training that I've got. So we do have some evidence, which I've presented, which I hope will convince some people here that there's at least something to explore. But like you said, you know, it's not the end all be all. And as I mentioned, one of my goals is to do some more multimodal work and to look at other modalities. So certainly something I'm interested in and happy to explore.
Okay, thank you. And I have a last question about the rehabilitation. And you are looking at the aerobic exercise and how the aerobic exercise can help concussion, which is a very, very good hypothesis and idea. That's exactly what you want to do. I am just wondering about the underlying physiological hypothesis that you have. What is the physiological link that you can see between aerobic exercise and concussion? How concussion interact with or how aerobic exercise can help concussion? From what is the underlying physiology? Is it the metabolism? Is it energy? Is it what kind of link that you can make? This maybe can help the hypothesis looking at the EEG, which part of the EEG is helpful to interpret the result, or as you mentioned, for the neuromodulation, what kind of signal you are going to look at. So if you have this underlying hypothesis, is there anything that we can find in the literature or that you know well, making it? Yeah,
it's not greatly, so the physiological consequences of concussion as a whole are not greatly defined. A lot of the work that's available is done in animal models, so how translatable or how equivalent that is to be determined. But essentially there's evidence to suggest that the autonomic nervous system gets disrupted. So essentially the sympathetic system becomes overrepresented and the parasympathetic nervous system becomes underrepresented. There's also changes in cerebral blood flow and neurometabolics, essentially by exercise training. So an individual exercise session will increase your sympathetic nervous system. It'll go the wrong way, but with sustained exercise training, it reduces the effect of it basically sort of helps balance everything, and you're in more of your rest and digest stage instead of your fight or flight stage. So the hypothesis from a physiological standpoint is essentially trying to help rehabilitate autonomic nervous system dysfunction.
Okay, so thank you very much.
All right, so thank you everyone for attending. That concludes our colloquium. I just want to also thank you, Dr. Teel, for your wonderful talk today. Seems like you have a few potential collaborators lined up for at the Perform Center. So thank you very much, and have a nice afternoon, everyone.
Thank you for having me.
Thank you.
Thanks.